If you haven't heard about Anchor, it's the easiest way to make a podcast. Let me explain. First, it's free. There are creation tools that allow you to record and edit your podcast right from your phone or computer. Anchor will distribute your podcast for you so it can be heard on Spotify, Apple Podcasts, and many more platforms. You can make money from your podcast with no minimum listenership. It's everything you need to make a podcast in one place. Download the free Anchor app or go to anchor.fm to get started. RNMD is a show about hospital relationships from the perspective of doctors and nurses. You're very smart, and we know that you would never come to a podcast for medical advice. So obviously, call your non-podcasting doctor and nurse team if you need any medical care. Oh, and we should also mention that we don't represent any hospital at all, ever. Okay, start the thing. Everybody, and welcome to another episode of RNMD, a show about doctors and nurses working together in this mad world of medicine. I'm Abby, your nurse host, and today I interviewed Dr. Stephen Bradley. He is an anesthesiologist. He's a musician. He's in the Navy. He is just all around amazing. And he also is interested in this humanitarian aid effort. He was on the USS Comfort. He is just a pleasure to talk to. He also has his own podcast, the Black Doctors Podcast, which highlights minority professionals and tells their story, which is a great platform. And I just personally love his podcast, and that's why I asked him to come on, because it's probably my favorite podcast right now. Even though I just started a podcast, I think I like his the best. So anyway, subscribe to this one, subscribe to his, the Black Doctors Podcast, and here we go. First of all, thank you so much for coming on the podcast. I'm so excited. I've been looking forward to this for a while.
Thanks so much for having me on, Abby. Happy to be here.
First things first, I just want to say that you have your own podcast, the Black Doctor Podcast, right?
I do. Yeah, it's been just finished this first season. It started over the summer. And I just look at the lives of different minority healthcare professionals and hopefully add some inspiration to students of color who are looking into becoming healthcare professionals or don't even know that, that's an option for them. So just kind of trying to gain exposure to the fields.
I've listened to about half of the first season and I love it so far. What was the reason why you started it?
In part, some struggles that I had with imposter syndrome and not thinking I was adequate or good enough. And as I talked to other colleagues and heard their stories about what they came from and the environments that they grew up in and the struggles they overcame, I was inspired by that. And I really wanted to be able to bottle that up and have other people be able to learn from those stories and be inspired by them. And I know with social media, like a lot of stuff can get kind of lost in the shuffle if it's not a glamorous picture or something that's really flashy, So I wanted a forum that has some staying power that people can go back to and access. And, if somebody knows somebody that needs that extra push or is in a similar situation, they can refer them to that episode and they could hear from somebody like themselves who's dealing with issues that they are dealing with. I love the logo. I heard you talking about somebody said something bad about the logo. Is that true? Yeah. So the logo, it was like the Black Doctors Podcast, and I wrote it out and I had this like thing in my head about what I wanted to look like. And I made a little video, and then my girlfriend, some of my friends were like, "Oh, it looks so bad." Cause it's all like this chicken scratch hand drawing. So I got one of my buddies to kind of make it look a little nicer, and that'll come out sometime soon with the next season. Okay. Well, for the record, I like the first one, and I think they just don't get it. Okay. So how much time do you usually spend on your podcast? Oh, wow. So each episode Usually I record for 30 to 45 minutes. I'm trying to do 30 to 35-minute episodes. And the post-production is what takes a while, as you know.
Mm-hmm.
I know we've talked about this, but it could take probably an hour to an hour and a half per episode. I go back and try and clean up all the and I try to take out a lot of that for both my guests as well as myself. I mean,
Right.
usually I'm spending most time cleaning up my own. Um, like that, we can edit that out.
Yeah.
And after I do that, I go back and fiddle around with the EQ and try and make it sound really good. I know the first like episode or two where I was still learning how to do the post production editing, the sound was a little off, and I watched a bunch of YouTube videos. And now I'd like to think it's gotten better, but it takes about an hour to an hour and a half to edit an episode.
You're fast, actually. It takes me so much longer. You're fast. I spend like a half a day, depending especially if there's 3 guests, I spend hours. Yeah. Oh my God. Because like you're saying, I mean, I want to make everybody sound as clear and as concise as possible. So I'm trying to edit out like everything except for right before they speak.
Yeah, my secret is I don't say much on my podcast. Like I think probably 80% of it is my guest speaking. So I don't have like it cuts down on how much I have to edit. It's a little cheap trick.
Yeah.
But 3 guests, like having to edit, I haven't had to do that yet. I'm gonna have to do it for an upcoming episode. And I've been dreading that.
Yeah, it's so annoying. What my trick a little bit is because oh my God, once you have a podcast, you realize how annoying your own voice is too. So like, yes. I started realizing that I'm like a really overactive listener. Like anything somebody says, I'm like, yeah. Like, so I just started to just edit out the whole chunk of while the person's talking, like my whole track is gone. Cause I'm just like, everything I'm saying is not essential.
Yeah. My thing is I'm always like, oh, wow. After they say whatever they said, wow. I'm like, God, how many times did I say wow in one episode?
Exactly. Mine's yeah. I'm like, yeah. Oh, yeah. Oh, yeah. Like the whole thing, like the Midwest accent comes out hard when I'm interviewing.
Where are you from?
I'm from Michigan originally. I've lived in New York since like 2013.
I was gonna say you do have a Midwest. I was in Chicago for residency, so
really?
Quite familiar with the Midwest and the Midwest accent.
Oh my God, Chicago's awesome. I love it there.
So much fun.
So, I guess tell me a little bit about your background. I mean, I listened to your first few episodes, so I got the gist. But for anybody who hasn't listened,
yeah. So I grew up a Navy brat. My parents met in college. They were first generation college students. They met at Florida State University, got married. The rest is history. But my dad accepted a commission into the United States Navy once he was coming out of college. So I grew up in a Navy family, a Navy brat, which that means every 3 to 4 years, active duty service members usually move to a different duty station. So we moved around a lot. So my home is kind of up and down the East Coast. My dad retired in Florida. So that's where I was for high school and for college. And after college, that's when I kind of realized I wanted to go into medicine. I completed a post-bac program in Tampa at the University of South Florida. And then I matriculated to Howard University College of Medicine in Washington, D.C. It's a historically Black college or university. So it has a very rich history and legacy. And after medical school, I proceeded on to the University of Chicago for 4 years of anesthesia residency. I think the most interesting thing about my background is just the diversity I was able to experience. I actually went to a religious school for undergrad. I was going to be a pastor for a little bit. I was going to go into the ministry for like a year that lasted. So I went to a religious school, then I went to a state school for the master's program. Then I went to a historically Black university for medical school. And then I think University of Chicago is like almost Ivy League. I don't know if they are or not. Sorry, people from University of Chicago, don't send me hate mail. But kind of that prestigious private school. So I've been able to dabble in all these different forms of education, a very religious background and upbringing, and then I've been kind of more open-minded over the years. And it's culminated in me pursuing a ethics fellowship at the University of Chicago. They have the McLean Center for Clinical Medical Ethics. And my last year of residency, I completed that concurrently with the anesthesia residency. And it's a full year where we spend, 4 weeks in the beginning every day, it's a full year program where we spend the first 4 weeks attending lectures from philosophers and psychiatrists, psychologists, lawyers, parishioners. And the group itself was very heterogeneous. It had physicians, physical therapists, nurses, social workers, and we all just kind of learned from each other and learned how to tackle different ethical dilemmas that we see in medicine. We would have weekly grand rounds where different groups would come. So there would be the surgical grand rounds, and the surgeons would be like, this is what we do in this case. And then the medicine folks were like, oh, you're crazy. And then the peds folks would be like, oh, yeah, this is, this pediatric case. And the surgeons are like, what's wrong with you guys? Like, it was just amazing to see the different cultures collide. And then we would navigate to kind of what the best options were and incorporate all those different ethical values and tenets and social cues and cultures. And so I think that's where my background kind of coalesces into where I am now. And I'm able to use all those different experiences in how I relate and interact with people. But in addition to, I guess, the rest of my background, I did follow my dad's footsteps into the military. So during residency, I accepted a commission and a little bit of scholarship money. So I'm in the Navy. I'm an active duty naval officer, and I've been in for 2 years, and I have a 4-year total commitment with that. So that's my whole background.
Wow, that's so interesting. So first of all, why anesthesia? Why did you pick?
Yeah, so in medical school, I didn't really know what I wanted to do. I thought I wanted to be an orthopedic surgeon when I first got there. Then I met all the other orthopedic surgeon types and was like, that's not for me. And I kind of floundered around for the first 2 years, wasn't really sure. And I had a really good friend who was super gung-ho about anesthesia. I had got my board scores and I was within the limits of being able to match in anesthesia. And the third thing that happened was being in DC, the American Society of Anesthesiologists had their national conference that year, right down the street from my apartment. So I was able to go and attend that. And I kind of made that a plan B as I went into my third year of medical school. And I was going to see what else I liked, but I had anesthesia as a plan B. I was starting to develop some connections in that field. And as it happened, I didn't really fall in love with anything. Actually, I did fall in love with surgery. I wanted to do trauma surgery. I loved working in the surgical ICU. I loved the critical care. I loved the complexity of the patients. And I remember one Saturday, I was in the OR with one of the trauma surgery attendings, and she was taking out a gallbladder. I was holding the camera, and I realized, like, oh my God, I hate operating. I hate the OR. I hate, like, if I had to do appies and gallbladders to make a paycheck, like, I would hate my life.
Uh-huh.
So I sat down and talked with her, and thank God, she was very nice and sweet and understanding. And she said, you can get to ICU from anesthesia, from internal medicine. There's all these other options. And when I found that out, I was kind of sealed the deal for anesthesia. And that's also why I went to the University of Chicago, because they have a really robust ICU program.
How does it work with the Navy? So if you're active duty now, you work directly for them, or how does that work?
Under the Navy, as I was coming out of residency, I had to email the Navy and be like, hey, I want to do an ICU fellowship. Then the Navy's like, no, we don't need additional ICU doctors at this time. So just report. They sent me orders. So my duty station and orders are to go to this military hospital in Virginia. There are multiple, they're called military treatment facilities. The large ones are in DC, Virginia, and San Diego, the three largest. And those would be our like academic hospitals. Mm-hmm. And then other bases have smaller hospitals. So like the Navy base in Jacksonville has a naval hospital, Pensacola, all these smaller outlying naval hospitals. And some hospitals have full surgical services, which would need spots for anesthesiologists and surgeons and CRNAs. And then some hospitals are smaller and more of a clinic and primary care type thing. And they wouldn't have billets or they wouldn't have assignments there. So when I come on active duty, they tell me where I'm going. It's a hospital with OR services. And thankfully, it's one of the big three for the Navy. So I'm at the teaching hospital that's here in Virginia. But I work full-time on active duty. What that means is day to day during the week, I come in and do anesthesia. Like today, I'm going in at 4, so I'm working overnight. And every day I have a schedule to work in anesthesia where I'm doing nerve blocks or general anesthesia or OR coordinator. And then as deployments come up, we get pulled and assigned to those different deployments. So last year, I had like a month's heads up. Well, I guess one of the coolest things I did was last year in the spring, the anesthesiologist down in Cuba in Guantanamo Bay needed to come back for a month of leave or vacation and take his boards. So I flew down to Cuba for a month, and I was down there practicing anesthesia at the hospital and backfilling for him. And then I went back to Virginia, and then like 2 weeks later, found out that the hospital ship was going out on a 6-month humanitarian aid mission, and I was assigned to that. So then I had like a month to get ready, and then went out for 6 months. And I came back in November, and then just went back to work at the military hospital.
I didn't know that they did humanitarian aid. Is that normal? Is that something you do regularly?
There's 2 hospital ships, one on either coast, the Mercy and the Comfort, and they've been in the news with COVID response. The ships have 12 operating rooms. I mean, really, we only use like 4 or 5, and CT scanners and a morgue and ICUs and wards. And they've been using them a fair amount for humanitarian aid. So the Mercy on the West Coast will go out, and they do like kind of collaboration with other host nations. It's all about building relationships with different nations. I don't represent the Department of Defense or the United States Navy, all that stuff. But so basically a lot of it's politics, and okay, we irritated our neighbors down south, so let's go out and send this beautiful white ship, and we'll do free surgeries and help people. And it just helps foster relationships between countries. And some of it goes kind of through the State Department. That's kind of the bigger mission. But for us as physicians and nurses and corpsmen, which are medics, we're just on the ship doing hospital stuff.
Wow, that's great. Do you have a choice of what, if you're a part of that, or if you're working at a hospital, or?
Yeah, there's a little choice. So every 3 years, that's how long the orders are for. So I'm up for orders next summer, and I'll probably just stay at the hospital for an extra year. And depending on where you are, so if you're stationed over in Rota, Spain, or in Japan, they're probably not going to pull you for a humanitarian aid mission or a deployment to Iraq or Afghanistan, because you're already kind of forward flexed. But at the bigger hospitals, and especially stateside, the hospital can function with X number of anesthesiologists and CRNAs, but the rest of us are up for whatever deployments may come. So you can kind of have a heads up of what's out there. And sometimes you can ask, I want to go boots on the ground and go to Iraq or Afghanistan. You can kind of navigate a little bit as you learn more and see what's coming down the pipe. And then depending on if you don't want to deploy, then there's other ways to kind of maneuver your career. Usually not when you're junior, kind of when you're the junior guy like me, you just get sent out a lot, which is what happens.
Right.
But there is some options a little bit down the line.
Yeah. So you've been on the USS Comfort?
Have I?
Because I saw
6.
I saw the picture of you with it.
Yeah, I spent 6 months on that ship last year. From June, we left June 14th and got back in November. We did 600 surgeries in total. Well, I guess 1,200 surgeries, but half of those were cataracts. So we had 3 ophthalmologists. There was an ophthalmologist from the Mexican Army, and then there was 2 U.S. Navy ophthalmologists. So they did like 600 cataracts. And then we did a lot of general cases like hernia repairs, gallbladders. We had a plastic surgeon on board that was doing cleft lips and cleft palates. He was a Navy plastic surgeon. And we had a plastic surgeon from, where was he from? Oh, he had an OMFS surgeon from Canada. We had a couple of different host nation or foreign national, like military folks that deployed with us. Orthopedic surgeon from Brazil. And we all just kind of worked together to do different surgeries and treated 1,200 patients surgically. And then there was a whole medical component that would go ashore and see patients at 2 medical sites and do medicine stuff.
Wow, that's crazy. That's so cool. I went to Haiti maybe like 2 years after the earthquake happened.
Yeah.
And I was there, and it was amazing. I mean, we were like a team. We were like a little traveling team, and we would, go way out and then we'd come back to Port-au-Prince, and we were kind of just like all over the place trying to provide,
Oh, wow.
pretty basic care, you know,
But it goes a long way.
it definitely does. And it was really rewarding, and it was amazing. So I keep, you know, it's always in the back of my head. I'm going to try to do that, you know, that kind of work again. It's hard sometimes because you're working full time, and, you know, it can be difficult. You have to pay a lot of times to go.
Yeah, absolutely. And that's one thing. I hadn't really done much missions work because I hadn't felt like I could contribute much. And I was actually set up to do like my first independent missions trip with one of my friends. She's an orthopedic surgeon, and there's a women's outreach global orthopedic surgery. It's all female orthopedic surgeons, and they go out and do orthopedic surgery. And I was supposed to do that with them this spring, but then COVID hit, so we're all kind of, you know, picked up the pieces. But the Comfort itself has been involved in so many different missions. Like, I think they went to New York for immediately after 9/11. They were in Haiti shortly after the earthquake. They were in Puerto Rico after the hurricane, and then Katrina. So the Comfort gets tasked on short notice. So anytime there's a natural disaster, so the whole time there's hurricane season, it's on like hurricane watch, and the crew can get pulled and deploy in like 48 hours to be headed out.
That's amazing. What kind of nurses are working on the Comfort?
Yeah, all kinds. So the Navy Nurse Corps, you know, thousands of nurses in the Navy, and it depends on the mission that they have. So there's like a casualty receiving area, which is the emergency department. So they have some ER nurses, they have ICU nurses because there's 3 ICU bays. There are med surg nurses, and the Navy kind of runs a little fast and loose. So you may be a med surg nurse, and so basically when they went to New York, it was all hands on deck. It didn't really matter what kind of nurse you were. You were whatever they needed. And a lot of folks got shifted into the ICU, and they had like an incredible level of acuity in the ICU there.
Really? I didn't realize.
What's that?
That there was a high acuity. I didn't realize.
Yeah. They, you know, they got a lot of transfers from outside hospitals of really sick patients. And
of non-COVID is what we were told, that ship was going to be non-COVID. So if we had non-COVID patients, we were to send them out, and then to keep keep the ship clean and the hospital dirty. That's what we were told.
Yeah. So when you mix military and medicine, what happens is a lot of stuff comes down from the top, and plans change on like short notice. So my friend was one of the ward nurses who had like a 10-minute heads up that, oh, we're taking COVID patients now. But that's the military. Like you just kind of deal with it and flex. So that was a plan, right? It was no COVID patients. And then I was watching the news because I was supposed to be on the ship, and then I got pulled off for various reasons. The mission like changed every like 48 hours to all of a sudden they ended up taking a lot of COVID patients.
Oh, I didn't realize that, because the impression that we got, and I've never worked on a ship like that, but the impression that we got was that if there was COVID, even one COVID patient on that ship, it would just spread like wildfire. Okay. So tell me a little bit about like your typical day. What is your day? Like, you're going to work tonight. What is that like?
Yeah. So tonight I'll go in, the overnight shift starts at 4. During the week, we do 4 p.m. to 7 a.m. And then on the weekends, we do a 24-hour call if we're on. So I'll take side out and see whatever cases are still running. There'll probably be like 2 or 3 cases running late, and I'll kind of check in to see where they're at. There'll be anesthesiologists or nurse anesthetists in those rooms. And after about 6 o'clock, I'll just take whatever comes in emergently. I'll be working with 2 anesthesia residents. And then there's a nurse anesthetist that's working on labor and delivery. We just kind of back each other up and help each other out with cases that come up overnight.
Oh,
but for a typical week, I would get the schedule the day before and see what patients I have, and go over their medical history the day before, and the resident I'm working with would call, and we would discuss the patient's medical history. We talk about the plan for anesthesia. There'll be a little teaching opportunity between myself and the resident. We'll talk about, what do you want to talk about tomorrow in the operating room? And then I would come in the next morning. Our ORs start at 7:30, and then we would start doing anesthesia during the day. As time permits, then I would do some in the room teaching with the residents that I'm working with.
Okay. And obviously you work with OR nurses, you work with PACU nurses. What type of
Yeah. So the full spectrum, like I didn't realize going into medicine how compartmentalized hospitals were. And like, there's not just a nurse, like a nurse is not like, doesn't do everything. So there's the perioperative nurses that greet patients when they first come in at 6:30 or 7 in the morning of surgery. They will take their history and kind of look over them and say, hey, are they okay for surgery today? As one of many checks that we do before going back to the OR. So they'll get them into the correct pre-op slot in the pre-op holding area. We have corpsmen, which are our medical techs. A lot of them will start the IVs for the patients, get them hooked up to monitors, and that's just the beginning. In the operating room itself, there is the operating room nurse or circulator and the scrub tech. So as part 2 of the safety check, the circulator nurse will come out and they'll talk with the patient, assess them for risk of DVTs, ask about allergies and different things. It's, probably the second or third time that they've been asked, and talk to them about the plan, make sure everything's squared away, consents are signed. And then the anesthesiologist or CRNA will come see the patient, with their resident or SRNA. It's kind of a third check, and we're doing our full exam, and I'm talking to the patient about medical history, any contraindications to medications or the anesthetic plan. I'm consenting the patient, telling them what the plan is for anesthesia, answering whatever questions they may have, and have them sign a consent form. The surgeon may have already had the consent form signed when they saw them in clinic, or they may come see them the morning of to sign that consent form and to mark the patient. So there's always like between 3 and 5 checks that happen before going back to the operating room. When we get back to the operating room, this is the OR nurse's domain. The OR nurse, the scrub tech, this is, the bane of all medical students' existence when you first go to the OR. And usually it's the scrub tech. I think some places there's nurses that scrub as well, and they protect that sterile environment with their lives. And some of them are nicer than others. That's one of the first lessons you learn is to not encroach in their territory and to respect the scrub nurses. And the ultimate goal is we want to keep the patient safe. But again, a lot of times it's how you approach people.
Definitely. I mean, I've heard that the OR nurses, I have a friend who's an OR nurse, and I've heard that they can be not just the nurses, the scrub techs also can be very intimidating.
Yes. Yeah. Very, very intimidating. We haven't even got to the surgeons yet. And a lot of it, it's just the unknown. People move so quick in the OR, and next thing somebody's bumped into the table and they've contaminated everything, and now you get to send it back, and then there's delays. So it's understandable. And then from the student's perspective, whether they're a new OR nurse or a nurse precepting or a medical student or PA or whatever, you're so preoccupied with just being in the OR. Do I have the correct equipment on? Am I wearing my hat? Am I wearing my mask right? Oh man, what is the surgery again? Who's the patient? Are there allergies? What do I need to know about the anatomy? I'm about to get pimped by the attending and the residents. Oh my God, there's 4 patients on the list. And you're thinking about all these things in addition to, oh man, I can't touch this blue drape. Oh my God, I think I backed into it. And then they're like, am I going to scrub? Am I not? They're yelling at me, wear your gloves. And, it's all this stuff that's going on in your head. You can't make heads or tails of it. Ideally, you'd come in, you'd have that conversation. You'd know, am I scrubbing or not? You'd be able to pull your gloves. That's the issue. Like some places, like the nice scrub techs and nurses that I worked with, a lot of times they'll ask like, what size do you wear, and pull gloves for you. Some of the oblivious people like walk in or scrub, and they'll just like stand there with their hands dripping wet, and they messed up already because they just assume that the gloves will magically appear. And I've seen like the scrub tech or nurse just stare at them like, well, what are you going to do? Wear your gloves. So then they have to like go
back out,
grab their gloves, open them, put them on the table, go back out and scrub. So that's kind of like the initiation or hazing, but it's all comes from just kind of lack of communication and just being overwhelmed in a new environment. So that's a lot of what happens in the OR.
Yeah. I think I've only been in the OR a handful of times, and each time it was as a student, and it was like, it was actually the times where people were being nice and looking out for me was also the time where I felt attacked in the moment, because the nurse would be like, stand here, don't move.
Mm-hmm.
Like she would be like, this is your corner, basically. And now looking back, I'm like, actually, she was looking out for me, because if I'd bumped the table, it would have been like the worst thing.
Yeah, there's often not a lot of time to really express the why behind it, but sometimes I'll talk to medical students, be like, hey, yeah, just stand back right now. Don't, it's not a good time.
Don't come close.
And I'm looking out for you. Little do you know.
Yeah.
But in the OR, it's like the OR nurses domain, and the surgeon comes in, depending on the hospital. At a lot of private hospitals, there's a very good rapport between the surgeons, the circulator nurses, the scrub techs, and they know exactly what the surgeon wants, what they need. And you'll see a huge difference in how efficient the surgeries are. Whereas in the teaching hospitals, residents are rotating. A lot of people I don't know how many people realize that residents rotate every month or 2 months. So every month or 2 months, you're literally brand new on whatever service, and you're trying to learn how everything runs. So those poor circulating nurses and scrub nurses are like, do they even waste their time trying to learn what size gloves you are? No, they'll just ask you what gloves you are, or have you pick your own. Does the surgeon like the techs to prep for him, or does he want the residents to prep for him? That's when you see the residents start prepping, and then the scrub nurse is like, well, yeah, doc so-and-so likes her patients prep this way. And then it's opportunities, the resident going to be like, cool, let me do it. Let me follow your advice. Or,
right. Yeah.
But in some of it, is how did that nurse approach the resident? Were they rude? Were they like, and then how was the resident? So all these like different personality types. And I just that's one reason I love anesthesia, because I'm sitting back here just watching all of it, taking it in. Like the psychology is it's just fascinating. I've had nurses at the outside hospitals tell me like, oh, well, the surgeon likes this type of anesthesia or this. And I'm like, okay, like I appreciate it, but that's something that I'm okay to go head to head with the surgeon with. And I'll find out from him, like him or her, just checking, cool, well, in this patient, this would actually be better. But I'm always receptive to feedback, because I know I assume that at the center of it is keeping the patient safe and helping the day go by smoothly.
Yeah, definitely. I would assume, though, everybody in that room could potentially have kind of a big ego. I mean, you think about a surgeon and an OR nurse who's been there for a long time, and maybe a scrub tech who knows that surgeon really, really well and knows exactly what to do. And like you're saying, I mean, the residents, they come in. That's something nursing, I don't think, is really aware of always, is that the resident is every month in a new place and trying to learn.
Yeah.
So it can be easy to be really frustrated with someone when you're just trying to get in, get out, do your job. It can be easy to kind of be frustrated and be like, oh, how do you not know that? But it's also kind of unfair when you're looking at someone who's maybe never even stepped foot in this facility before.
Right. It cracks me up, because like looking at, when nurses do preceptorship, which is what I think third or fourth year of the BSRN or BSN programs, is that?
It's hard for me now, because mine was different. I've been a nurse for like 12 years. So.
Oh, really?
Yeah. Yeah, I was like a baby when I started. Yeah.
Yeah, but you see like the nursing students on preceptorship, and they look like a literal gaggle of ducklings, like they're still lost, and they're learning how to do that's double checks on medications. They're on the floor, and they just come in like a herd.
Yeah.
And it's the same thing, right? It's just, okay, these residents have been in school for 4 years longer, but every month it's a completely new environment. And then by the time, for surgery residents, by the time they're second or third years, they've started to kind of repeat. They know the circulating nurses, they built that rapport. If they're nice people, then they're friends with the OR nurses and scrub techs. If they've got some ego problems or a little off-putting, then maybe not so much, but at least you are familiar with the system, and that's half of the battle with the upper level residents, and that's why they function so much better. They know more of the medicine, they know more about their surgical colleagues, and they know the system.
Yeah, the system, that's a big part of it too, because that can be, it can make somebody, like you're saying, like even like a nurse maybe who has like a little bit of an ego, it can make that nurse be very like, well, how do you not know this very simple thing? And it's like, well, they just don't know how this hospital works, you know, and that's like kind
Yeah.
of a simple thing you could just help educate, you know.
Yeah. So then in the OR, the surgery happens, there's a couple of timeouts. And it's important to note, I'm a big advocate, part due to the ethics fellowship in the background. I'm a huge advocate for anybody being able to speak up at any time. And there's been so many times where I've heard, from the nurse or somebody that's kind of voiced a concern, but they kind of mumble it. And I'm like, stop. This concern was raised. Like, and I will amplify. If I hear somebody expressing concern, I will amplify your voice and back you up to whoever I need to, because I know you're doing it out of concern for the patient. And people can be frustrated at me. Like I'll take that. And so I just try and back up whatever voice needs to be heard. But it's important that if you see something wrong, that you say something before, we go down a path that's irreversible. If something's got contaminated, you got to speak up, because it's all for patient safety.
Definitely.
During the case, the OR nurses are working with the surgeons and getting different devices that they need. A lot of times what happens is, okay, we need blood emergently. And at my hospital, it just so happens that oftentimes when something's going horribly wrong, the nurse is tied up getting stuff for the surgeons. So situational awareness, look around. The nurse is busy. I can call the blood bank, so I'll just call the blood bank. Hey, can y'all get blood ready? All right, cool. And then the nurse comes up to be flustered, like, I got to call blood bank. I'm like, no, it's cool. I called him, and it's fine.
Yeah.
So it's all like the whole team, and then my residents are kind of, they don't know, because where I trained in the different residency programs, residents are expected to, in anesthesia, do 100% of the things by themselves. And as far as teaching goes, I do try and teach at independence. But when crap's hitting the fan, I make it clear to them that, hey, we're working together. And you do that, I'll do this, and we'll get through this together. So my residents are kind of uncertain, like, oh, hey, like, did I do something wrong because I didn't call the blood bank, or because I didn't do this, or because I didn't get this IV? And I'm like, no, just you get the IV, I'll call the blood bank, and we should work together as a team. That's what I try and foster in the residents that I work with and the OR nurses that I work with.
Yeah, that's a great approach, because I've been there, right? I've felt like, especially maybe during a code or something, like, should I be the one doing all? It's like, especially if you're new, you kind of take the burden of everything on yourself, and just hearing that from somebody who's a little bit above you can just make you feel like, okay, no, I don't have to do everything. There's a reason why there's a team here. I did my part. Yeah. I can go home feeling like I did my job today, So let's talk about a conflict that you had with nursing. I'm going to put you on the spot.
I had quite a few, actually. So, because, like, I'm not one that worships nurses like, oh my God, they're God's gift to earth. I don't worship physicians that we're God's gift to earth. We're just freaking people, and we each have a job to do, and that's all. Like,
same.
Doctors do your job, nurses do your job. That's what I expect. And so, I mean, I'm like a really nice guy once I get to know you, but usually at work, I'm just kind of like, no crap. I just expect us to all do our jobs. So that said, I generally have a really good relationship, especially in residency, with the CTICU nurses, best nurses I've ever worked with. But I learned early on in residency how different things can be perceived. What's her name? Her name was Jessica. So I was in pre-op, and I went to see this patient, and it's such a stressful time. I think you talked about this in previous episodes in terms of nurses giving a report. There's different times in the day where it's just tough, and everybody's trying to get to the patient. So before surgery, the OR time is 7:30. And if you're late, you're going to get dinged, and eventually you get in trouble. So there's so many things to do: set up the OR, go consent the patient, start the IV, all of this. And we're all trying to get to the patient at the same time. And Jessica, we're friends now. Or we've been friends like the whole time. I just had to learn this one quick thing. She was in there. She was in the room talking to the patient. But when I poked my head into the curtains, like, she wasn't talking to him. So I waited a couple seconds, and there was no communication going on. There's a pre-op check sheet or flow chart that the pre-op nurses are filling out. So I waited like a good 10, 15 seconds. There was no communication happening. So I rolled up. I was like, "Hey, Mr. Smith, how you doing? Steven, I'm the anesthesia resident. I'm working with you." And as I started talking, out the corner of my eye, Jessica was typing on this computer on wheels, like one of the cows. And I just see the cow just kind of ghost rider drift all the way across the bay. And, and she got so pissed off, she just shut it and was like, "I'm done." Like he freaking interrupted me. And I was like, "Oh my God. I have pissed off Jessica." So I finished my interview. I talked to the patient, and then like later on in the day, I went and found her, and I'm like, "I'm so sorry. I thought you were done talking to the patient, and I won't let it happen again." And she was nice about it, and she's like, "Yeah, accept my apology." And from that point on, and it's to this day, I make it a point to say, "Is it okay if I talk with the patient?"
Mm-hmm.
And that alone has just helped alleviate so many conflicts. Everybody feels heard, everybody feels respected. Because it's happened to me also where I'm in the middle of consenting somebody, and I mean, probably every other week people assume that I'm not the doctor. So I'll be in the middle of I'll be in the middle of consenting my patient, and then somebody just walks in and starts talking. I'm like, okay, well, that's kind of a very important process that you just interrupted. So I learned that from Miss Jessica, and we're friends, and we moved on past it.
You moved on.
But all the PACU nurses knew, like they were laughing because they like, some of them saw it, and then the story had spread. Like, oh my God.
Talk about more. You just said that you get mistaken for not being the doctor regularly. I mean, do you want to talk about that?
Yeah, I think just whether it's being young, whether it's being Black, I don't fit people's image of what a physician looks like. Mm-hmm. In residency, I actually grew locks. So I had locks down to my shoulders. And I think, I just didn't meet the typical description of a physician. So yeah, I understand it. I get it. When you're used to seeing things a certain way, we all have our internal biases. And that's how we live our lives. So I look at those as kind of teaching opportunities. And one, I've just expanded somebody's concept of what a physician looks like. So I think that's the good side. Mm-hmm. And it also depends on how the interaction goes. If they're just confused or surprised, great, that's a teaching opportunity. If they're kind of rude or aggressive about it, then I don't know. I gotta, I'm a little spicy in response, but respectfully. Definitely. But I'm like, no, I am the physician, and I will kind of affirm or reaffirm my role.
How does it make you feel when that happens? Do you have like an emotional response?
It depends on again how they relayed their frustration or dissatisfaction. An emotional response, not so much. Sometimes it's a surprise because I'm not expecting that. In the middle of everything else that I'm thinking about, it's like, oh, okay. They don't think I'm a doctor. All right, we'll handle this and move past it. Sometimes, if it's going to present a barrier to care, or there's a lack of trust, or now I need to go get my attending because they said they wanted somebody else to do the anesthesia, then that's pretty frustrating and it's unfortunate that this occurs. Sometimes there's a lack of trust.
Yeah.
But it did work out a couple of times. Again, the CT ICU, the cardiothoracic ICU, those nurses were the best nurses I've ever worked with. And I remember one weekend we had one of those difficult families, that the wife's in the hallway, like antagonizing the nurses. Where's the physician? I haven't seen the doctor, blah, blah, blah. And I was on 24-hour call that weekend. I think I had, 18 or 20 patients. And I was literally standing right next to them, wearing a white coat, wearing scrubs, typing into the computer on wheels. And I was making my way down to see each patient after rounds. I was literally standing right next to this patient or this patient's wife. And she's like, "I want to see the physician now." And she kept going on and on. And the nurses looked at her, and they looked at me and saw I was busy. They're like, "Okay, he'll be with you shortly." I mean, she's went back in the room and waited, and I was able to finish rounding, and then I came back and talked to her. But I'm like, hell yeah,
like covert over here.
Yeah. So the relationships can make or break you in medicine.
Definitely. I think that's why it's so important. Your podcast is so important. And that's really why I wanted to talk to you. Because it's really important that we change the idea of what somebody is going to, their preconceived bias about what a doctor looks like or what a nurse looks like, or, so I really applaud you for your initiative, and I love the podcast, and keep up the good work. I'm so happy.
Abby, thank you for your page. It's holy crap. Like, it's unfortunate that we can't have civil conversation about this because people just go far right with everything. Like I see the responses that you post in your stories, and like sometimes I'm triggered, but I'm like, oh my God. Like,
me too. I mean, there are two people kind of like trolling me right now. One of them is not even in healthcare and is like, the wage gap isn't real and all this stuff. And
yeah, I saw that.
I was like really upset about it. Like that's why I had to take a break last night. I was like, this is getting to be a little much for me. And then I just was like, you know what? I'm going to let other people deal with these two guys. Like, I'm just going to screenshot exactly what they're saying and put it. And my approach too is like, I don't like the whole like, oh, you said one thing and now like we're all going to jump on you like a mob. I don't like that either, right? So it's like I'm trying to find a balance of like, how can I open up discussion and actually try to reach you, without you, because the second people start to just attack and swarm, and then it's like the person pulls back and they're just like reaffirmed in their own beliefs, So I'm really trying to like reach out and be inclusive, but also be like, this is messed up what you're saying. Like,
yeah, there's that. There was the Ohio State University thing with the.
Oh my God, crazy.
Because that guy, like, I tell every single person, take what I say with a grain of salt. When I'm teaching my residents, I'm like, it doesn't sound right, look it up.
Yeah.
But the momentum just,
oh my God. It was crazy. And then did you see it was on that, what is it, nurse meme page or whatever, posted something about doctors, about like how, like, oh, you guys have gotten really good at treating patients from a computer.
Yeah.
Like, you're not going in the rooms and whatever. And then Eddy Joe, I don't know if you know him.
Yeah.
He
like, I think I unfollowed that page from something else that they'd done. I was like, I just can't take this. But I saw your screenshot. I couldn't see what else he said though.
Yeah. So I had previously unfollowed them about something totally unrelated. And sometimes he'll post stuff that's like borderline like sexism.
Yeah.
And like, so then he posted that about the doctors, and like, listen, we had doctors who didn't go in the room during COVID. But by and large, we had doctors who got COVID. We had doctors who were in the room. Some of the MICU consult docs, they were in the room more than anybody. So it's not fair to just say it as a generalization either. That was like, I thought that was really unfair. And then Eddy Joe posted, and he actually called me. His wife is a nurse. He loves nurses.
Yeah. Eddy, he's very, very, very pro. He's more pro nurse than I am. I'm kind of like, all right, everybody just do your freaking job.
He loves the nurses. And then they swarmed on him. It was like crazy. No. Yeah. And he called me. He was like, did I say something wrong? I was like, you didn't say anything wrong. Everybody will move on. It's like a day of outrage, and then they move on. They don't care anymore. Yeah.
But it is so nuts. I mean, it's just not a good medium to have these conversations. Like, these are just so frustrating that a lot of times I just can't follow them anymore.
Yeah.
So insane how big the outrage is, and then how quickly it goes away. And that's what the culture is. And then I think a lot of people don't realize how much variability each hospital has. Because I've been at pretty much academic centers, but you get out into community hospitals, and like I started moonlighting at a community hospital. It's like, holy crap! There is no ICU doc here overnight. It's the electronic guy. It's the EICU, and then like the other hospitals where nurses have a lot more autonomy, or like where the physicians are not in-house overnight. Like, that was kind of mind-blowing to me, because teaching hospitals is always a physician in-house.
Right.
But there's other hospitals where there's not.
Nobody.
And I'm like, whoa.
Yeah.
And so those nurses have more autonomy. They do more stuff. And it's just like that clash of culture that people can't understand or accept, that things are vastly different.
Yeah, it's just crazy. I don't know. I feel like it's like ramping up. I hope it kind of evens out, and like, I don't know. It seems like that's not happening.
Yeah, and you're kind of you're stuck in the middle of it.
Kind of, because I don't want to I don't want to take a stance. I just want my thing to be my thing. That's what I want.
Yeah.
Absolutely. Yeah. You're doing great things. I wouldn't worry about it.
Yeah, just trying to help I don't piss off. I hope I'm not the center of a Dr. Pimple Popper scandal.
Same. I mean, even for me, coming at it like the doctor isn't the worst person and the nurse isn't perfect. Even for me, it's scary sometimes. And it just closes the dialogue. Like,
and then there's the docs that are like, I love nurses. Nurses are the best. Nurses are God's gift to earth. And I'm like, okay, it's somewhere in between.
They don't even mean that shit. They don't even mean it.
Like, I shouldn't have to kiss somebody's ass to have them provide good patient care. They shouldn't have to kiss mine. Like, we should all just be professional. I think I'm realizing I'm very naive because I just assume we're all going to be professional and do our jobs.
I mean, unfortunately, too, for me, sometimes some of this is like rhetoric. Oh, this year, I know that it's Doctor Day, but like this year, I think we should give this one to the nurses and like blah. And I'm like, this doctor does not mean that shit. Like, stop. It's like, if it's a compliment. Like. Yeah, it's like, actually that insults me more. I'm like, if you have some shit, say it. That's fine. But like, don't like pretend, and because it makes me feel like you think I'm dumb, that I need like.
Right. Yeah. Because if you took a private nurses chat and saw what they said about physicians, and if you took a private physicians chat, so the fact that Ohio State's textbook went viral.
Yeah.
Like, do you not think that's what
people are saying?
Most residents think, but you're upset because, so it's, Abby, I'm on the fence though about one topic, and that is how people treat medicine as, those sayings like medicine is for people that can't see themselves doing anything else or whatever. Like, they kind of make it all
like a calling.
Or like a humanitarian, you have to be, you can't do medicine for the money.
Right.
And I don't fully subscribe to that. Medicine, nursing, all of those, in my opinion, are jobs, they're trades. And that, yes, you may be more altruistic when you go into that, but you shouldn't talk down on people that are like, oh, I'm here to be. I think there's a balance that I'm wondering about talking about, but I don't know if I'll get castigated for exploring that space.
I think that already is happening, honestly. I don't think you should feel like you can't talk about it. I've seen other people, because at least when I started nursing, it was that older generation of nurses that I was trained by. It was like the baby boomer generation, and the culture of their generation is like martyrdom. I mean, really, especially with nurses. And it was very much like, we don't take our lunch break. We don't take vacation. We don't know. I'm here for the patient. And they would literally break their backs to provide care to their patient. And with our generation, I think we've all tried to realize that, like, well, one, that just leads to burnout. It's not sustainable, right?
Yeah.
And then you find these really jaded providers who don't care about the patient anymore because no one asked them, and also no one asked you not to take your lunch. You can take it.
You have a contract. You have
it's better for everyone. So I think that conversation is already happening. Like, people now I see more making fun of, like, nursing is a calling, it's like, no.
Right.
All right. Well, thank you so much for everything. I really appreciate it. And I hope to talk soon. Maybe if you want to come back on, we can reschedule. We could do this again sometime.
Yeah, no, thanks so much for having me on. I just, thanks for highlighting the show, the Black Nutters podcast. So season 1 is done, and I am starting to record episodes for season 2, which hopefully should come out in September. Mm-hmm. That's kind of the big project I'm working on. And it should be a little more diverse in terms of, I've got some dentists and trying to get some veterinarians and some other health professions to have some more representation. In addition to that, I'm trying to delve more into medical ethics. So on my Instagram, Stephen Bradley MD, I'm trying to put out weekly episodes where I discuss different topics in medical ethics or different ethical scenarios based upon what's happening in the news media. So definitely check that out if you're interested in medical ethics.
Definitely. That's a great idea. I'm excited to listen. All
Thanks
right.
so
Thank
much.
you. Thank you so
All
much.
right,
Have a good
talk
day. All right.
All right, bye.
Thank you, everybody. Please stay safe out there. Thank you so much for listening. If you like the show, please rate us. Please subscribe. We really need the love right now. This is a new podcast, new idea. We really need some support. If you have any topics, please email us at rnmdpodcast@gmail.com. Thank you, guys. We appreciate you.